Evening, and thank you for joining us for tonight's Antenatal Share Care Obstetrics update on hypertension in pregnancy. My name is Alex, and I'm the Population Health and Chronic Disease Program Officer with Central and Eastern Sydney. I'm joined tonight by my colleague Lydia from the CPD team. Before we commence this event, on behalf of CESPN, I would like to acknowledge the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water, and community, and pay respect to elders past, present, and emerging. I also extend that respect to Aboriginal and Torres Strait Islander peoples joining us tonight. Now I would like to introduce the facilitator of tonight's session, Dr. Rebecca South, a GP at Leichhardt General Practice, clinical lead at Inner Women's West Women's Health, and GP advisor of the RPA Canterbury Antenatal Share Care Committee.
So I'm a GP in Leichhardt. I've been a antenatal shared care GP with RPA in Canterbury for a long time, and it gives me very great pleasure to introduce Dr Patrick Lan, who's well known at RPA.
So thank you for the introduction. So as you know, my name's Patrick, one of the nephrologists over at RPA. I'm heavily involved in the management of hypertension in pregnancy, both in the clinic and inpatient, outpatient. Inpatient and outpatient for settings. So to begin with, in terms of pregnancy and blood pressure, we know that blood pressure does fall in the first trimester, and it reaches the nadir in the second trimester before rising back to preconception levels by term. And the definition, which has been around for a long period of time, has been just having a systolic blood pressure greater than 140 millimeters of mercury, or a diastolic blood pressure greater than 90 millimeters of mercury. And in terms to confirming high blood pressure, it's always been suggested that repeat readings over several hours should be performed, usually over 4 hours in terms of the period of time. So in terms of trying to talk briefly about this area, I think the easiest way to do so would be to go through a number of simple type of cases that you would generally see both in the clinic, in your clinic, and we see them referred to our HCP clinic. So first of all, we have just say a 30-year-old female who's recently found to have a positive urine pregnancy test. So she's come in to see you to start the ball rolling, no significant history. And surprisingly, when you check her blood pressure is elevated on this first visit. What should you do? I guess this is a common presentation, common situation which you might see in clinic. So in terms of what should you do? Well, obviously you still should follow the routine antenatal screening tests, which in addition to that, you would want to make sure that you check the kidney function. So the EUCs, particularly being a nephrologist, that's important. And we'll also having her to do a MSU and spot urine ACR or PCR. In the past, I don't know if you recall, but they've mainly been focused upon doing a spot urine PCR. But nowadays there's been, it's acceptable to also do a spot urine ACR instead. And then you would referring for the patient for a dating ultrasound to confirm the viable pregnancy. And given how the blood pressure was, the 145/80, you could ask the patient to monitor their blood pressure at home. And that is becoming increasingly more common with the increasing availability of home blood pressure monitoring devices. And we can talk about this a little bit later on. And also can consider otherwise a 24-hour blood pressure monitor. And after doing this, organising for her to return back to the clinic, ideally we'll want her to come back to the clinic within a week for reassessment of her blood pressure. So in terms of ambulatory blood pressure monitoring, the main role of ambulatory blood pressure monitoring in this group of patients is more in identifying white coat hypertension. It's particularly useful in women before 20 weeks of gestation. And we don't really use ambulatory blood pressure monitoring in the second half, or rarely use ambulatory blood pressure monitoring in the second half of pregnancy. So as you can see here, just a little flow diagram as to the use of ambulatory blood pressure monitoring. So if you had an office or clinic blood pressure greater than 140/90 millimeters of mercury before that 20 weeks of gestation, then you could consider doing a 24-hour ABPM. And I understand that it's becoming a bit more commonplace in use of ambulatory blood pressure monitoring, given, I guess, how that also Medicare, there is now Medicare reimbursement for using 24-hour blood pressure monitoring in patients who are not on blood pressure medications. In terms of the goals or the targets, it's a little bit lower than what you may have seen on normal 24-hour blood pressure monitoring in a general population. But 130/80 awake, but at night 115, which is a bit lower than the 120/70 that's generally quoted in the general population. So apart from 24-hour blood pressure monitoring, home blood pressure monitoring is very commonly used now. Now, at the moment, I guess there haven't been any real recommendations on the use of home blood pressure monitoring, although there have been lots of statements from societies such as SOMANS and so forth to suggest that home blood pressure monitoring can be used to help monitor how response to treatment and also assist in diagnosis. The aim in home blood pressure monitoring is for the average blood pressure to be less than 135/85, so a little bit lower than what you see in clinic in terms of the 140/90. Now, in terms of the studies, I guess the studies have been still somewhat limited, but the greatest benefit is that it's able to reduce the need for patients to continue to follow up in clinic. So you're not having to have the patient come back to clinic the next day just to monitor their blood pressure. It's a good means of giving us an idea as to whether they do have white coat hypertension or potentially mask hypertension, although that's not what you'd be looking for in the majority of cases. Now, in terms of blood pressure monitoring, and I'm sure the list is changing all the time, but in terms of validated machines, you can see here on the column on the left is the list of validated blood pressure machines. This is probably a couple years back now, validated for use in pregnancy and particularly in hypertension in pregnancy too. So the numbers there aren't great compared to what, or aren't so big compared to how many different devices are available. So it's always good just to ensure that the patient has a device that may have been validated, and also you do have to be wary of the fact that devices, if once a device is beyond a couple of years of age, then it may need to be recalibrated. So that's just something to keep in mind. So this is from the SOMANS, most recent SOMANS guidelines, which were published last year in terms of how to measure your blood pressure at home, which is pretty much the same as how you would be asking all your patients to measure their blood pressures at home. So making sure that they've rested at least for, they say, at least for 5 to 10 minutes. Making sure that you're in a quiet environment, making sure that you're seated, feet flat to the ground. And I guess the most important part is not to just take one reading, but to take multiple readings, at least 1 or 2 minutes apart in terms of and I guess accepting the readings once you can see that the readings are pretty close, it's similar. So if we go back to the lady that we were talking about, so she's come back to your clinic again a week later. She's had her dating ultrasound, which has confirmed the pregnancy, the viable pregnancy. And she's been measuring her blood pressure at home, and it's consistently sitting at 140/80. Now, the blood pressure in clinic, you've measured again it's slightly elevated at 145/80, but she remains clinically well. So, and all your other screening tests that you've done, the full blood count, EUCs, all the hepatitis and everything is all normal. So what's your likely diagnosis and what should you do now? I guess it's a bit hard in terms of asking questions to such a big over the computer. So I guess in terms of what is likely going on now, given the fact that the blood pressure was high on the first visit, blood pressure is high early on in pregnancy, it's more likely that the patient in front of you has chronic hypertension. And this is hypertension confirmed either before pregnancy or before 20 weeks of gestation. And as you all know, chronic hypertension may be classified as either being primary or essential hypertension or secondary hypertension. Now, in terms of investigation, it's a little bit hard in terms of investigating for secondary hypertension at this stage during pregnancy. And this is something that should be looked at a later time after pregnancy. So in terms of looking at starting medications, well, there's a limited number of medications that can be used in pregnancy. The more common, the ones that we have available are methyldopa, labetalol, and nifedipine. There are a couple of other medications that could be used, but these are generally, well, methyldopa and labetalol in particular are generally considered first-line agents. And as you can see in terms of methyldopa, it's centrally acting. The main contraindication to using methyldopa is depression. It does have a bit of a slow onset of action. It can, because of it is centrally acting, can cause a bit of dry mouth and be somewhat sedative. And in terms of withdrawing or stopping the methyldopa, you just need to be aware about the potential risk of having rebound hypertension. Now, labetalol is a beta blocker. So the main issues would be in patients with asthma or chronic airways disease. And there have been sometimes some women who've unfortunately had a worsening of their asthma being placed on labetalol. In terms of nifedipine, it's a calcium channel blocker. Best to avoid in instances of aortic stenosis, although I guess that should be highly unlikely in this group of patients. The main side effect that that patients do complain about are headache, which usually does improve with time, and they can sometimes can also cause a bit of a tachycardia. So ideally, you'd start with methyldopa or labetalol, and if needs be, you could add on nifedipine if necessary. So then, in terms of ongoing management, and I understand that the majority of GP doctors here work around the Sydney Local Health District area. Referral to our antenatal HDP antenatal clinic, either at RPA or Canterbury Hospital. Dr. Winter does a clinic there now at the Canterbury Hospital, would be appropriate. Now, the titration of the antihypertensive medications to a goal of less than 135/85, and ideally 4 weekly monitoring at this early stage of the pregnancy. And the other thing to consider would be preeclampsia prevention. Now, in terms of the 4 weekly monitoring, this is a slide or a table from the recent SOMANS guidelines, which, as you can see here for the columns, the left two columns, the white coat hypertension and the chronic hypertension columns, the idea is to at least have a 4 weekly visit in the clinic to monitor the blood pressure. It's very good to check the proteinuria, so a urine dipstick is very useful. 1+ protein on urine dipstick isn't significant, but greater than that can be significant, and be good to do a more formal test if you do get that result. And then in terms of biochemistry, so when we talk about biochemistry, we're talking about full blood count, EUCs, LFTs. No need for regular biochemistry assessment in the clinic unless the blood pressure suddenly changes or there's a change in clinical situation. So when we're on that last point from the previous slide in terms of preeclampsia prevention, and you'll be likely to be seeing this out in the being used, particularly in the last 10-15 years. The use of aspirin as a means of preventing preeclampsia. It can reduce the risk of developing preeclampsia by up to 70%. In terms of when to commence aspirin, it should be commenced before 16 weeks of gestation. However, ideally, we'd like to commence it around 12 weeks if possible. And the recommended dose is 150 milligrams nocte. This is just a table of comparing the use initiating aspirin either before 16 weeks or after 16 weeks of gestation. And as you can see here, the benefit is much greater, or there is a improved risk reduction by initiating the aspirin before 16 weeks of gestation. Whilst the dose, because there are different formulations, and because a large majority of the studies were done in the US, where they have even doses of aspirin of 75 milligrams, they found when comparing doses that the use of the 150 milligram dose of aspirin also reduces the risk greater of developing preeclampsia. The main thing is, as you can see here in the middle there, though, is that the risk reduction is greatest in reducing the risk of developing early onset preeclampsia. And by definition of the early onset preeclampsia is preeclampsia that develops before 34 weeks of gestation. So this is just a patient information slide, which was included in the recent SOMANS guidelines to actually explain to patients or patients who have been put on aspirin as to what why they have been put on aspirin and when to take it and so forth. So as you can see here, starting it before 16 weeks, taking 150 milligrams and taking it before bedtime. So I guess that brief look at a single case of someone that was being found to have high blood pressure on initial presentation, so before 20 weeks of gestation. So those principles, or what we talked about, can also be applied to other similar situations, such as a woman who comes into a pregnancy with chronic hypertension. So in terms of the medications, you want to make sure that you've changed the medications to the appropriate pregnancy safe medications, labetalol or methyldopa, prior to trying to fall pregnant. Again, in terms of pre-pregnancy counselling, beyond just the chronic hypertension, but also women who have had previous hypertension or preeclampsia in pregnancy. So talking about starting aspirin at around 12 weeks of gestation. And women who have been screened as being high risk for preeclampsia on the combined first trimester screening. And so being considered high risk is having a risk greater than 1 in 100. So then moving on to case number 2, and sorry about the unoriginality of the ages of the patient. So a 30-year-old female who's 24 weeks gestation, has presented for her routine antenatal appointment and has been found to be hypertensive, 150/95. What should you do? So the most important part of this, particularly in women that are beyond 20 weeks of gestation, is trying to determine whether this patient has preeclampsia versus gestational hypertension. I guess I've already assumed that we have found that the blood pressure is consistently elevated, that it's a true blood pressure reading. So trying to look for preeclampsia versus gestational hypertension. So we assess for the signs and symptoms of preeclampsia, which we'll go into a bit further on. The urine protein assessment is very important, like we've mentioned previously. And given the blood pressure, I think seeking obstetrics advice is important. And within the local district, speaking to either the on-call obstetrics registrar or the patient's private obstetrician. And also at this point, considering commencing a patient on, or you should be commencing the antihypertensive medications, but again, that would be with advice from the obstetrics or renal, and referral to the HTP clinic would be appropriate. So in terms of preeclampsia, preeclampsia, as you all know, is a multi-system disorder of pregnancy. It's characterized by being by hypertension and involvement of one or more of the other organ systems and or the fetus. The more common of these is proteinuria. So it's high blood pressure, so greater than 140/90, plus something else. And we most commonly see the urine protein. Nowadays, there was up until about 5 years ago or so, when you were making a diagnosis, you needed to have high blood pressure, proteinuria, plus potentially something else. Or if you had high blood pressure plus just say a headache, it didn't get classified as preeclampsia. But nowadays you don't need the proteinuria as being essential for the diagnosis. Just a very quick or a small diagram on looking at the pathogenesis of preeclampsia. And as you can see, the number of factors such as oxidative stress or genetic factors, all causing the placental dysfunction, which then leads on to the growth restriction and the release of the vasoactive substances, which then go on to cause the hypertension, the proteinuria, the liver dysfunction, the cerebral edema. So in a way, you can see this diagram sort of clearly shows how it's not just a placental or fetal issue or just a blood pressure issue, but actually an issue covering a wide range of, potentially covering a wide range of organ systems. So in terms of risk factors for preeclampsia, and this is important also if we go back to the first case that we talked about, the patients with high risk factors are ones that you would consider starting them on aspirin for. So high risk factors could include a history of preeclampsia, those who have been hypertensive in previous pregnancies, women with CKD, chronic hypertension, diabetes, and autoimmune disease, so SLE, antiphospholipid syndrome, and so forth. Lower sort of other risk factors, which I guess then encompasses a whole additional women would include things like having a high BMI, having an IVF pregnancy, having a multi-pregnancy. So these are other things to consider, but really the high risk factors are important here. So in terms of your diagnostic criteria, or hypertension arising up to 20 weeks. And as we said, involvement of one or more of the following. So the renal involvement, most commonly proteinuria, so a spot urine PCR greater than 30, and nowadays also or a spot urine ACR greater than 8. An elevated creatinine greater than 90. Oliguria, which I guess is more of a quite, which would show quite sinister or something quite worrying signs. Hematology involvement, so hemolysis or thrombocytopenia. Liver in terms of epigastric pain or epigastric tenderness, which could be related to the liver capsule. Also raised transaminases, so greater than 70 for the ALT or AST. Neurologically, we're talking about things like hyperreflexia with clonus, with sustained clonus, so more than 2 or 3 beats, more than 3 beats of clonus, really. Headaches, visual disturbance such as visual scotometer, stroke, and convulsions, which really is then the patient has actually gone on to develop eclampsia, which is really the reason why we want to treat the blood pressure, is to prevent or treat the preeclamptic patient is to prevent them from developing eclampsia. Pulmonary edema, fetal growth restriction. Now, if the patient doesn't have any of these other signs, then the patient has gestational hypertension. So this is new hypertension after 20 weeks without any other organ involvement. And usually in this group of women, they do return back to normal blood pressure, return back to normal within 3 months of pregnancy or postpartum. Up to 25% of these women actually go on to develop preeclampsia, however. So that's why these women should still have pretty close follow-up or pretty close monitoring. However, they are associated with little increase in risk of adverse pregnancy outcomes. And in terms of investigations, to try to determine whether this lady or this patient has either preeclampsia versus gestational hypertension. You can see here a list of tests that should be done. So the FBC, the EUCs, LFTs, like we talked about, the spot urine protein assessment, uric acid, which I have there as a second. An elevated uric acid can be associated with preeclampsia. It's not definitive, and so you could have preeclampsia without an elevated uric acid, but you could also, an elevated uric acid also doesn't mean that you actually have preeclampsia. Ultrasound assessment, and this obviously would be done by the obstetricians. And one thing that you might be seeing now more commonly is the SFLIT PLGF ratio. And this has really started to be used a bit more clinically more recently, and obstetricians are starting to use this to try to determine whether the patient has preeclampsia or not. And it should only really be used if there are features to suggest preeclampsia, but you're not sure. For instance, if you had a patient with chronic kidney disease and elevated creatinine, or already had proteinuria prior to pregnancy, but you've gone beyond 20 weeks of gestation, and the blood pressures come up a bit, but they otherwise look well, then you might consider doing an SFLIT PLGF ratio to sort of give you an idea as to whether you think this patient has or will go on to develop preeclampsia. So in terms of talking about the SFLIT PLGF ratio, this wasn't the initial study for its use, where it was a prospective multi-center observational study, which found that in women with singleton pregnancies, the preeclampsia can actually be used to predict the development of preeclampsia. So a ratio less than 38 had a very good negative predictive value. So if you had it less than 38, you can be reassured at least that the patient wasn't going to develop preeclampsia in the next 1 to 4 weeks. That's probably all you really want to talk about in regards to that. So back to that lady. So in terms of ongoing management, well, at the present time, when you saw her again back in clinic, there wasn't any evidence of preeclampsia on examination or on pathology or on imaging. Everything looks great. And you were starting her on medication. So like we said, you're targeting a blood pressure less than 135/85. Now, in addition to those 3 medications we talked about earlier, you can see here, hopefully you can sort of see that in terms of there are a couple of other medications that you could use. Clonidine, I don't know how familiar people are with the use of clonidine, but again, it's a centrally acting agent. Again, you do run the risk of rebound hypertension with its sudden withdrawal, and again, also can cause depression. But the problem with clonidine otherwise is that you shouldn't be using clonidine if the patient is already on methyl-dopa. The other medication that we can also use is hydralazine, and this is considered a second-line agent. The only problems with hydralazine is that it is very short-acting, and as you can see here, the dosing can be even up to 4 times a day. So it's something that we would use more second or third line, in addition to if the patient's already been on methyl-dopa, labetalol, or nifedipine. And it's something I guess we usually start in hospital because it's much easier for a patient to take something 4 times a day in hospital compared to doing that at home. The main issue, I guess, with the hydralazine is patients can sometimes get a bit of a headache, but also a tachycardia. So I guess this lady has moved on to gestational hypertension. So moved on to the third column here, where she should have at least weekly antenatal visits. Again, having the proteinuria assessment every time she comes into clinic, and also having a bit more in terms of a lower threshold for checking the biochemistry. With her pregnancy has further progressed, and she's gone on to 30 weeks now, and she's actually contacted the obstetrics. She's complaining of headaches and spots in her vision, and her home blood pressure readings have now been going up to 165/90. If she contacted you, the best advice to do would be to get her to either present to delivery suite or actually urgently contact the obstetrics team, because she definitely needs to be assessed to make sure she hasn't gone on to develop preeclampsia, and also whether, and in terms of the preeclampsia, quite significant preeclampsia. And so she's gone on to the delivery, which has confirmed all the elevated blood pressure readings. So your diagnosis is, like we said, preeclampsia. So in terms of your ominous signs or severe signs, where you're talking about blood pressure greater than 160 or greater than 100 in terms of diastolic, proteinuria more than a gram, oliguria, the creatinine going above 90, or your platelets dropping below 100, or signs of hemolysis. We mentioned the ALT, AST being greater than 70 is a particularly bad sign if they've got epigastric pain, or if they've got any neurological signs or symptoms, so the persistent headaches, the visual disturbances, the hyperreflexia, and the sustained clonus, or they've gone into pulmonary edema. So those are quite are very serious signs, and may lead to a decision for early delivery at that point. So going on about this severe hypertension, according to from the latest SOMANS guidelines, is having a blood pressure more than 160 over 110, and these really should be managed with IV therapy to begin with, in addition to the concurrent use of oral agents too, because they will at least sustain the blood pressure lowering. So because, for example, the IV medications that we have available, IV hydralazine or IV diazoxide, they do wear out really, really quickly. So if you haven't given them any oral agents, the blood pressure is not going to stay down. And mag sulfate, which I guess you're only using when you're in hospital, so you may not be too familiar with. So, and I don't really want to talk too much about this, but in terms of the target blood pressure in these severe instances, is that you really want to get that blood pressure below 160 over 110 to begin with, and then aiming to go below the, aiming to target 135/85 once you get below that threshold. So in terms of the ongoing management, like I said, the goal for blood pressure remains unchanged, so still the 135/85. And the other, I guess the other decision that needs to be made is the timing of delivery, which the obstetrician will do with some input from us as well in terms of both maternal and fetal indices. So that's I guess a case, trying an illustrative case of someone with preeclampsia or gestational hypertension that went on to develop preeclampsia. Now, this is also something that you will probably commonly see in the clinic in terms of postpartum. You do see postpartum hypertension is not uncommon. So just say for this case, we have a 35-year-old female who's 1 week postpartum, who's had an uneventful pregnancy, but she's actually come into your clinic because she's been complaining of a headache. And then when you've examined her, you've actually found that her blood pressure is 155/95. So one thing to consider is postpartum preeclampsia. It is rare and most commonly occurs within like 7 days after delivery, but it can still occur up to 6 weeks post-delivery. It's a similar presentation compared to when pregnant, and the management principles are the same. Patients, depending upon the blood pressure level of blood pressure, may need to be referred urgently to the hospital. They are at risk of developing eclampsia, although in my experience, the risk of developing eclampsia in these women drop off significantly after 2 weeks postpartum. And clearly, if you're having any concerns, we're happy to be contacted, either myself or Dr. Vaughan, who's one of the other nephrologists involved with the HCP clinic at RPA, or Dr. Winter over at Canterbury Hospital, to discuss what should be done. I guess in these cases, your main thing is that you would want to, once you confirm the blood pressure, is commence her on medications. And like I was saying, depending upon the level of blood pressure, she may or may not require admission in the hospital. I think in the severe hypertension, yes, definitely. in that mild to moderate hypertension, so in that area between like 140 to 150, 160, potentially she can actually be managed, the patient can be managed as an outpatient. So given the blood pressure was high, she went into hospital, and then she's now presented back to your clinic after discharge from hospital. She's been placed on multiple antihypertensive medications, which I'm sure you've seen on occasions, nifedipine, labetalol, hydralazine, and you're sort of thinking, what do I do? What should I do? Well, in these cases, particularly with the number of medications that she's currently taking, she definitely needs to be seen at least weekly to begin with, and this can be the case up until 6 weeks. Ideally, you'd want to try to wean off the short-acting medication. So if you remember that list that we had up there, ideally you'd want to stop the hydralazine, labetalol before you stop the nifedipine. And you can start reducing the medications when you can see that the diastolic blood pressure is consistently below 80. We can use ACE inhibitors in Alapril in postpartum. It's safe in breastfeeding. In these women, avoid NSAIDs because these can unfortunately increase the blood pressure. At the same time, her blood pressure may actually start to drop quite precipitously as well. So you just need to be mindful of hypotension. And the blood pressure goals in these cases are probably not as strict. So 150 over 100 is getting the blood pressure at least below that threshold to begin with. Now, hypertension can persist up to 3 months postpartum. So you should explain to the patients or to the women that not to be too concerned that they're still on medications a month or 2 months post-delivery. However, if the blood pressure stays elevated beyond 3 months, or they're remaining on blood pressure tablets beyond 3 months of pregnancy, then you'd want to be looking at doing a 24-hour ABPM, looking at secondary causes of hypertension, and even referral to renal for further investigation along those lines. And then just briefly in terms of you probably field a lot of questions from women who have had preeclampsia or have had blood pressure issues in pregnancies about what are her risks in the future. And as you can see here, there is a recurrence risk of developing blood pressure again in future pregnancies, and particularly more so in women that have had severe or early onset preeclampsia, this last box here on the right. And one thing that has become increasingly obvious in the last 5 to 10 years is the fact that preeclampsia is actually can sometimes or can be a window into the patient's future cardiovascular health. So as you can see that these women are at an increased risk of developing chronic hypertension in the future and cardiovascular disease, ischemic heart disease, these top 2 lines up here. So nowadays we're focused on not just saying that once the preeclampsia is all settled, everything's done and they're well and there's no future implications. Nowadays we are aware that these women should have regular GP checkups, at least an annual review, looking at their blood pressure, their lipids and so forth to try to, and also being on the healthy lifestyle measures as well. So this is also from that latest SOMANS guidelines, and as you can see here, if we go down to the 3 to 6 month postpartum and yearly reviews, where we are trying to address this issue of future cardiovascular risk in these women. And just here, this is a little patient sheet or a patient information sheet to show them that they are at this increased risk of developing these metabolic diseases in the future, or hypertension, cardiovascular disease in the future, and it's a good idea to try to adopt healthy lifestyle measures at this point in time. So I guess the main practice points for you in the community and would be that, well, first of all, there's a limited number of blood pressure agents that are safe, as you can see. And sorry, got something in the throat. Pregnancy You've got those, and then breastfeeding. You can also use enalapril. Preeclampsia occurs after 20 weeks. Remember, it's hypertension plus any other organ involvement. Most commonly proteinuria, but you do not need to have proteinuria. Your blood pressure goals, so 140/90 in clinic, but now 135/85 in home readings. Postnatal, a little bit more laxed. And in terms of postpartum preeclampsia, it can occur, but it's most likely within a week after delivery. And just to remember, there are long-term implications of having had a preeclampsia or hypertension in pregnancy. So these are women which should continue to have sort of an ongoing relationship with yourself to at least assess for things like hypertension and cardiovascular disease. This is a link from the, I think, district health that the district that they wanted to, that I think would be useful for everyone to at least have a look at if you have any issues or concerns. It sort of covers what we've talked about, gives you contact details if there's any questions. That's username and password. And just briefly, our HDB clinic, we run those on Tuesday mornings at RPA and Wednesday afternoons with Dr. Winter in Canterbury. And the women that we see, anyone who has a hypertensive disorder of pregnancy and women considered to be at high risk. Sorry, I think I'll probably have to in there. These are just some contact details, both at RPA and also at Canterbury for if you're unsure. Cool. I think I'll probably leave it at that and can probably do some questions.
Great. Yeah, thank you so much, Patrick. Now, I must apologise, my video is not working well. Do you want to just grab a little drink or something? That you did very well to keep on going.
It's only going to be another 10 minutes, that's fine.
Yeah. Well, that was great. What a very comprehensive kind of overview of, and really always really good to use cases. I think it really helps us remember. I think we'll all learn through stories. So someone had a question about that particular woman who developed high blood pressure, who had high blood pressure postpartum, and just wondering about in that clinical case, was she actually sent straight in, or was she actually done blood and urine?
So blood pressure was very high.
Very high.
She was and plus she had a headache as well. So I guess you're worried about preeclampsia. So it doesn't just happen in pregnancy. You just have to be aware it can still happen postpartum as well. So yeah, she was definitely sent in, and blood pressure was a bit tricky or difficult to control initially, but and then left hospital with multiple medications, unfortunately, but had to be slowly weaned down over time.
Yeah. And then just a couple of questions too about well, I guess on that point, at what point would you sort of, how long postpartum would you start to be less concerned that it may be pregnancy related?
Yeah, so I think in terms what we do see and what I've seen is that up to 2 weeks postpartum is probably your risk, there is that risk of developing preeclampsia and eclampsia still, okay? And then beyond 2 weeks, your risk of eclampsia sort of drops off quite significantly. So beyond, and the main reason why we're treating the blood pressure in these women is that we're it's associated with reducing the risk of developing eclampsia. So, so I think beyond 2 weeks, it's a little bit less, you're less anxious, less worried. In terms of blood pressure, as you can see, our blood pressure goals post-delivery are a little bit higher compared to what they were during pregnancy as well. You can still develop preeclampsia up to 6 weeks postpartum, but I think I think after 2 weeks, you're sort of a bit more reassured that that's less and less likely.
Yeah. Okay, great. And just a couple of questions from people just about how you might advise to wean down on something like labetalol
Yeah,
postpartum. Yeah, I mean,
yeah.
often they are discharged with some very good instructions, but sometimes we
Yes,
do
yes. Sometimes
need
it's
a
not
bit of
not so
advice. Yeah.
true. Um, so in terms of so things like with labetalol, I think starting to wean medications if you're noticing that if the diastolic blood pressure in particular is dropping below 80, you can actually start reducing medications. I think good advice also is that if the patient's systolic blood pressure is dropping below 100, 120, then you can also start reducing it. And in terms of reducing it, I wouldn't initially probably start slowly. So a lot of the time women are on TDS dosing. You might want to just drop it down to BD to begin with before then, and then halving the medication, and you might do that over the course of a week or so. In terms of if they're on quite heavy doses, so I guess if women are on like 400 TDS of labetalol, rather than just dropping straight to BD, you might drop it down to 300, then drop it down to 200, and then drop it down to BD dosing after that. And again, like you'd probably be looking at making some changes every it's hard to say because everyone's a little bit different, but I think to begin with, you'd probably be changing things over a week. And then as you know, are more confident that the blood pressure is actually more and more steady and more stable, then you can actually make those changes a little bit, a bit more quicker. So 3 or 4 days and so forth. Hopefully that sort of clarifies it a little bit. And in terms of hydralazine, you want to be a bit cautious. You don't want to just stop hydralazine because you can get a bit of a rebound hypertension, similar with the methyldopa or the clonidine. We don't use a lot of clonidine nowadays, but in the past there was a lot of clonidine use. You want to sort of slowly wean those down every few days if once things are steady, rather than just stopping it completely in one go.
Great. Okay. Well, that was really great. Thanks so much, Patrick. That was very useful for all of us. And now I think we're going to go on and hear about drugs and alcohol use in pregnancy. So thank you so much for your time this evening, and thanks so much for all the work that you do. I often get fantastic letters back from you, so thank you.
No problems at all. Well, thank you. Hopefully that was useful. Okay, thank you.
Okay. So everyone, I do apologize about the video not working this evening, but we'll move right along with our next speaker, who some of you may know. She's also very well known around Central and Eastern Sydney PHN area, and Dr Hester Wilson, who's a GP and Chief Addiction Medicine Specialist at the Ministry of Health Centre for AOD, and who is going to give us an update on alcohol and other drugs in pregnancy.
Fantastic. I've just got a 5-minute quick update. And look, thank you so much. I'm Hester, I'm a GP, and I'm an addiction specialist working in Southeast Sydney and in Central Sydney as well. And I'm just really wanting to just flag the issues of substance use in pregnancy and parenting. Before I go any further, I would like to make an acknowledgement of country and acknowledge the Gadigal people of the Eora Nation on whose lands I'm on tonight. Now, look, first up, nobody wants to harm their baby. Unfortunately, all substances, including nicotine, alcohol, and other drugs, have risk in pregnancy. And it's something that we need to think about, asking all women about this. And I would flag also women of childbearing age, really as part of the conversations that we have, whether it's about contraception or checkups, women's health, really just flagging that while they might not be thinking about pregnancy now, it's important that they think about the impact of substances on a pregnancy. And these impacts can happen very early. And when we think of something like FASD, those effects can happen before the woman even knows they're pregnant. And that is a lifelong disability that is potentially preventable, but is it has issues for a group of people in our communities. So prior to pregnancy, at the first antenatal visit, and revisit it, asking all women, we're in a good place to do this. And sometimes, my colleagues will say, well, do we need to do this? Is it part of our role? They're going to be asked at the antenatal clinic. Well, hopefully they're going to be asked, and hopefully they're going to be asked by a number of people in a supportive, non-judgmental way that allows women to think about their substance use and how they want to change it. It's a time when women are really keen to make those changes. They're really committed to it. And for some, it can be really tricky for them because they actually have a substance use disorder or a substance dependence. And I will never forget the one woman that I saw who was caring for a child with significant FASD, who had an alcohol dependence, went to a GP, talked about her alcohol use, and the GP said, look, you're an addict, I can't help you. And it just breaks my heart. If only that GP had said, look, this is really important. Let's get you in contact with the people that can help you do this. We don't have to do it on our own, particularly if people have really significant issues that they're dealing with. We can get help from the substance use in pregnancy and parenting teams. We have them in Southeast Sydney. St Vincent's is through Southeast Sydney, through the Royal Hospital and Women's Switchboard, and the Sydney Intake Line. Sydney also has an email address, and I've asked them to get that up on Health Pathways and get it into their publicly available information. Also go to Health Pathways for referral options for alcohol and other drugs treatment. So it was really just wanting to raise this as an issue, and to think about it, think about asking the question, including nicotine, alcohol, and other drugs, including as well pharmaceuticals. So the ones that might have an impact on pregnancies, for example, antidepressants, antipsychotics, those kinds of medicines as well, to make sure that they've got the best balance for the pregnancy. I wanted also to flag that hot off the press just came out in July is the new New South Wales clinical guidelines for the management of substance use in pregnancy, birth, and the postnatal period. It's available free online. If you just look up New South Wales SUPs, it'll get you there, or New South Wales Clinical Guidelines for Pregnancy. Really great information. It is directed at drug and alcohol services, and maternity services and paediatric services, but there's good information for us as GPs as well. So that was it from me. It was just a quick flying visit just to let you know about the new guidelines and to encourage you to think about asking about nicotine, alcohol, and other drugs. We are in a unique position as GPs to support mothers, babies, and families to actually achieve the best outcomes they have, and to support those who need a referral, who have significant illnesses and complex needs. And I would just, if you haven't had any experience of the teams that work with substance use with families and women in pregnancy and postpartum, they're incredible. They're incredible teams. They are really good at engaging with families, supporting families, and really shifting those outcomes, much better outcomes for the women themselves and their families, and also for their children. So that's all I wanted to say. I don't know if there's any questions from anyone. Very happy to take questions.
Great. Thanks, Hester. We'll wait and see if anything pops up in the chat. But I just wanted to just ask you about, so as a GP, I think we've all started using Health Pathways a little bit as a useful resource. Is it actually within the antenatal information some of the links to substance disorders in pregnancy? And if not, can we get it on there?
That is a really good question. I went looking at this because I thought surely it's going to be in Health Pathways. It's not great. There is a mention about asking about alcohol in the Southeast Sydney pathways. Couldn't find anything in the Sydney LHD pathways. There's certainly good drug and alcohol sections, and you've got the referral or the request sections that send you in the right direction, but not specifically in pregnancy. So I've been busily writing feedback to both of the Sydney and Southeast Sydney Health Pathways saying, hey, can we change this? And I certainly would encourage, because I know CESFIN runs it and I know that there's priorities around which pathways are put in place, but this is a really important one. And, and I think for me, really close to my heart is the alcohol one, which is a preventable disability. If we can help women to not drink at all during pregnancy, and certainly the guidelines around the risk. In the past, we'd say encourage not to drink. Now it's really clear that we're saying they should not drink. There are real risks, even with smaller amounts of alcohol, of causing impact on the baby. It, of course, gets much worse as the amount of alcohol goes up. So certainly in my role, it's around really making sure that women that have alcohol dependence can achieve abstinence and maintain that. But for us working in general practice, really having those conversations, and don't forget about nicotine, whether it be e-cigarettes or tobacco, really important. That has effects, as we know.
Okay, well, that's great. Well, maybe that's something we can all work on and with the CESFIN team as well to try and get that up onto Health Pathways, because it's hard to remember all these things when you're a GP, but it's good just to remember if there's somewhere you can go to get the information that you need. Yeah.
Totally.
Great. Okay, well, that's great. I think we'll probably sign off there, everyone, and the evaluation survey will be sent out to everyone. And thanks so much. A very useful webinar. Alex, would you like to close? Anything else you'd like to say?
Thank you, Beck. I just wanted to thank everybody and the presenters, Dr. Wilson, Dr. Lan, and you, Dr. South, for facilitating this event. Thank you for attending, and please complete the evaluation survey.